Welcome to set 2 of our internal medicine review questions. If you haven't yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. As you know, I provide my videos for free. However, the cost of putting together these videos and the time that it takes is offset by viewer donations. So if you could be so kind as to consider donating to my page, this is the link. If you do donate, you'll have access to a few of my premium videos in which I go over case reviews, formulating differential diagnosis and treatment plan, things that will come in useful for you, particularly as you study for the USMLE, and also for clinical practice, because as you know, real life is not a multiple choice test. Our first patient, question 1, 58-year-old man complaining of pain in his left wrist over the last 4 hours. He says that he's had this pain on and off but does not come in until now because he's uninsured. He rates the pain as a +8 out of 10. It's aching in nature and does not radiate. He is not on any medications, and his past medical history includes type 2 diabetes, which was diagnosed 10 years ago. He denies smoking, alcohol, and drug use. Vitals are stable and within normal limits. Physical exam is significant for some redness and swelling over the affected joint. Range of motion is limited in that joint due to pain. There are no sensory abnormalities of the left wrist or hand. CBC is unremarkable. BMP shows a sodium of 141, potassium 4.1, chloride 99, bicarb 24, calcium 9.4, uric acid 4.2. Wrist x-ray is unremarkable. Synovial fluid analysis is significant for a white blood cell count of 29,000 with 65% neutrophils. Positive for rhomboid-shaped, positively birefringent crystals. Which of the following is the most likely diagnosis in this patient? A. Osteoarthritis, B. Gout, C. Pseudogout, D. Rheumatoid arthritis, E. Septic arthritis, or F. Charcot-arthropathy. Okay, the answer here is C. Pseudogout. Okay, why is this pseudogout? Well, I didn't need to give you any of this information except for the last 2 sentences, and you could have gotten this question right. Rhomboid-shaped, positively birefringent crystals is diagnostic of pseudogout. Okay, if you see rhomboid-shaped, positively birefringent crystals on a test question, boom, it's pseudogout. Okay, very, very easy for that purpose, because if you know that, then you've got your diagnosis. They're probably not going to come this easy on the test, but I figured we'd start out with an easy one. Okay, so the way that this guy presents, it could be gout or pseudogout. Okay, because gout and pseudogout look identical for the most part on presentation. The difference is going to be your synovial fluid analysis. That's why we always have to get synovial fluid analysis even if we're sure that the patient has gout or pseudogout, because we need to know, is it gout or pseudogout? Because the cause and the treatment differ. Okay, so what about osteoarthritis? Well, he's 58 years old. Could he have osteoarthritis? Sure, but osteoarthritis is not going to give you crystals. Okay, simple as that. Okay, so he might have osteoarthritis, but there's 2 things working against that. The pain is off and on, and it's episodic. So with osteoarthritis, it's going to be more or less an everyday thing. And it's not going to be as severe. It's not going to be an 8 out of 10. It's going to be dull, achy pain that is persistent, not episodic. Gout, you don't know. Okay, you don't know if this is gout or pseudogout based on the presentation. The only thing that tells you that it's pseudogout and not gout is the crystals. RA, why not RA? Well, RA is going to affect small joints, so it can affect the wrist, but usually with RA, it's going to affect multiple joints and it's going to be symmetric. So it's not just going to be one joint on one side. Okay? If he came in and he said, both my wrists hurt, they're swollen, and my fingers are swollen, and by the way, I'm not 58, I'm 28, because RA typically presents in younger people for the first time, not older people. Older people have RA, but they don't present for the first time with RA at such an old age. It's possible, but not common. Okay, so it's not RA. RA is polyarticular and symmetric, and it's not episodic so much. So with RA, usually they'll wake up with pain, it gets a little better with time, go back to sleep, wake up the next day, pain again. Gets a little better with time, go back to sleep, wake up, pain again. Okay. Whereas with this guy, it's been on and off, but more episodic, not really correlated to anything. So his age, the style of the pain, and the fact that it's only in one joint works against RA. Septic arthritis. Well, look, he's got a white count in his synovial fluid. Why is it not septic arthritis? Septic arthritis usually will show up with a fever. Okay, it'll be one-time deal. He gets it. If it usually won't go away on its own, but it's not going to be something that comes and goes. And then the white count itself. Yeah, you have a white count with septic arthritis, and you have a white count with gout and pseudogout, and you can even have a white count if you take out the synovial fluid with osteoarthritis. But with septic arthritis, that white count is way high. It's going to be beyond 50,000. Okay, we don't see that in this patient. So fever, very high white count, and sort of a one-time severe pain is septic arthritis. And then Charcot arthropathy. So this one I kind of put in as a curveball. Charcot arthropathy is also known as neuropathic arthropathy, and this is different because it's not going to really show up with pain as much as it's going to show up with deformity. What happens with Charcot arthropathy, why it develops in the first place, is because these patients have a peripheral neuropathy, which often does come from diabetes, and that reduces their ability to sense pain. And so because they can't sense pain, if they injure a joint, they're not going to know it, and they'll continue injuring it, and ultimately that causes a deformity. That's Charcot arthropathy. Doesn't present with pain, not like this, not the kind of pain that causes you to come into the ER. Okay, so that's Charcot arthropathy. So you want to know how to distinguish gout from pseudogout, and what it really comes down to is the crystals. Okay, with gout, they're needle-shaped, negatively birefringent. They may be described as yellow. They look yellow under the microscope if you align the red compensator in a certain direction. I wouldn't worry about that. I don't like that they tell you the color because you can tell the difference just based on the morphology of the crystal. And then also, when you take the synovial fluid out, it's not like with gout you have this yellowish synovial fluid, and with pseudogout it's blue-tinged synovial fluid. They only have that color under the microscope. Another big difference is the composition. So with gout, they're urate crystals. With pseudogout, they're made of calcium pyrophosphate. And that has to do with the etiology. So with gout, it tends to come with a high uric acid level. But I say that cautiously because not all patients with gout have high uric acid levels. Likewise, not all patients with high uric acid levels have gout. Same with pseudogout. Not all patients with pseudogout have high calcium levels, and not all patients with high calcium levels are going to have pseudogout. Okay, so like in this patient, if you look, his calcium was actually normal, but he has pseudogout. Okay, likewise, you can have a high calcium level and not have pseudogout. Okay, so they're associated. They're not causative. All right. And then the white blood cell count, it's sort of medium. Okay, so it's high, but it's not high to the point of like septic arthritis, which is going to be like 70, 80, 90, 100,000 white blood cells in the synovial fluid. The treatment for gout and pseudogout is NSAIDs first. That's the first thing you do because you want to treat the pain first. Colchicine can be used for prophylaxis, just like in gout. The difference is with gout, you can use some of those uricosurics, those uric acid level dropping drugs like probenecid and stuff like that. Doesn't have any role in pseudogout. Okay. Colchicine works better for some reason for gout than it does for pseudogout, but we still use it to try to prevent pseudogout episodes. The important thing is that you look for an underlying cause. So if you have a high uric acid level for gout, you want to look at what might be causing that high uric acid level. Same with pseudogout. If you have a high calcium level, you want to look into what might be causing that high calcium level and then treat it. So if they have a high calcium level and they have a high parathyroid hormone level, then you want to look into possibly a primary hyperparathyroidism. Okay, so you want to manage the underlying cause. But the immediate treatment is NSAIDs. So here are your crystals, and this is with gout. They're needle-shaped crystals, very fine-looking crystals. And then with pseudogout, they're rhomboid-shaped, much fatter, plumper-looking crystals. Okay, question 2. We have a 27-year-old woman coming in complaining of facial pain. It's been occurring almost daily over the last few weeks and is severe, but it's intermittent, and the episodes last only seconds. Okay, so severe intermittent pain almost daily. She rates the pain as a plus 10 out of 10, but says she's not having any pain right now. The pain is sharp and radiates along the cheek from the right ear to the right side of the mouth. She cannot think of any precipitating factors, but says that it often occurs while eating. She is otherwise in good health and has no history of rash. Vitals are stable, physical exam is unremarkable, and there's no apparent trauma or sensory deficits along the affected area. Which of the following is the most likely diagnosis? A. Trigeminal neuralgia, B. Cluster headache, C. Migraine headache, D. Postherpetic neuralgia, or E. Multiple sclerosis. Okay, and the answer here is, you can pause it if you want. The answer is trigeminal neuralgia. So trigeminal neuralgia, this is very classic presentation. Very, very short but severe episodes of facial pain, and typically it's only on one side. It's not going to alternate sides. It's on the episodes only come on one side. They go away on their own. Usually by the time they get to the medicine cabinet to try to take something for it, it's already going away. So they're very, very short-lived episodes. Now, contrast that with cluster headache. A cluster headache is also unilateral, severe, and intermittent, but there are a couple things that are different from trigeminal neuralgia. Most importantly, the location. With trigeminal neuralgia, it's the face, along the distribution of the trigeminal nerve, usually the mandibular branch, so going along the jawline. With cluster headache, it's behind the eye, so totally different location. Also, with cluster headache, the episodes tend to last a little bit longer. It's not really a matter of seconds, more a matter of minutes, all the way up to like an hour. So much longer episodes than trigeminal neuralgia, but it's really the location that's going to give it away. Migraine headache, same deal. It's usually retroorbital, often usually only on one side, and very severe, but they last longer and the location is different. So migraine headache and cluster headache, you can partially distinguish it by by how long the episode lasts. Migraine headaches often last hours, whereas cluster headaches is more minutes. And then migraine headaches tend to have an aura with them. In some cases, they don't have to. And then there's like a photophobia where they need to get out of the light, they need to get away from sound. There may be precipitating factors behind the migraine headaches. Some people will say real loud music or maybe chocolate. A lot of these patients will be able to put some kind of trigger to it in many cases. Postherpetic neuralgia looks just like trigeminal neuralgia. Okay, they look very, very similar. The difference is with postherpetic neuralgia, it's associated with herpes. Okay, postherpetic neuralgia. So they get an outbreak of herpes on their face, for instance, and then after that, then they get this pain, and it's just like trigeminal neuralgia. It's the only way you're going to be able to tell the difference, really. The nice thing is, the treatment is the same, so you don't really need to know the difference. And then multiple sclerosis. This, usually we're going to see other symptoms, so motor symptoms, sensory symptoms, ocular symptoms. It's not just a pain issue. Now that being said, trigeminal neuralgia often does occur in patients with MS. I think it's somewhere around 2% of MS patients have trigeminal neuralgia, which is like 20 times higher than the general population. And then a lot of patients with trigeminal neuralgia happen to have MS. But the fact that this patient's otherwise in good health and doesn't have any other neurologic signs doesn't suggest MS. Okay, so you want to know your different kinds of headaches, and I included trigeminal neuralgia here as kind of like a headache because it's a pain that's in the head area. So obviously different from migraine and cluster headaches just based on the duration and then the location as well. So trigeminal neuralgia is really the only thing that's going to give you pain along the jawline. Migraine is going to be usually behind the eye. Cluster headaches usually going to be behind the eye. They're both unilateral as well. So really, trigeminal neuralgia stands out pretty good. Differentiating migraine and cluster headaches can be a little bit harder, but just remember that migraine headaches usually, a lot of times have an aura. There's nausea and vomiting, photophobia, phonophobia, whereas cluster headaches, you get more of those autonomic signs like sweating and lacrimation and flushing. Okay, so trigeminal neuralgia, a lot of times these patients will say that there are certain triggers. So some patients will say it comes on when they're eating, or maybe if they're drinking something like a cold beverage. Some patients will say they go outside, they get a little bit of a breeze on their face, and then they get an episode. So all sorts of different triggers that can be associated with trigeminal neuralgia. Physical exam is going to be unremarkable. There's nothing grossly wrong with these patients, and when they're in between episodes, they're their normal selves. They just get these episodes that come on. The diagnosis is really just going to be based on history. The thing is, you'll see some doctors will get an MRI when a patient comes in for the first time and they're diagnosed with trigeminal neuralgia, just because of that association with MS, and they want to make sure there's no MS there. But for the test, I wouldn't think of getting an MRI with trigeminal neuralgia. It's kind of overkill. The treatment of choice for trigeminal neuralgia is carbamazepine, but really any anti-epileptic drug is fine. So you'll see Lamictal and Dilantin thrown around. But carbamazepine is classically the treatment of choice, and it's going to be what comes up on the test. If that doesn't work, you can try other anti-epileptic drugs like Lamictal and Dilantin. But medical treatment alone is going to be successful in about 3/4 of patients, the vast majority. There are surgical things that can be done, but that's outside the scope of the test. Trigeminal neuralgia will remit on its own, usually within a year, so they won't even need to continue taking the medications. Okay, so now we have the same patient coming in 10 weeks later, and she's complaining of pain on both sides of her face now, as well as bilateral eye pain, which is worsened by movement of her eyes. She says that her vision has worsened and her glasses no longer help her see properly, and that she thinks she needs a better prescription. Physical examination is remarkable for eye pain elicited by movement. Facial tone is intact. Visual acuity is 20/70 bilaterally, which is reduced from 20/40 bilaterally. When swinging the flashlight from the left pupil to the right pupil appears to dilate when exposed to light. Which of the following is the most likely diagnosis in this patient? A. Bell's palsy, B. multiple sclerosis, C. adverse effect of carbamazepine, D. myasthenia gravis, or E. Lyme's disease? All right, and the answer to this one is multiple sclerosis. All right, so you might have thought, oh, adverse effect of carbamazepine, why not? I mean, we just put her on carbamazepine and now she's coming in with problems. Well, the adverse effects of carbamazepine, the real big one that you need to know, it has nothing to do with this patient, is Stevens-Johnson syndrome. So that's why we sort of titrate the patient up on their carbamazepine dosage. That's the big one. Some of the other adverse effects of carbamazepine are really nonspecific, things like dizziness, drowsiness, nausea, vomiting, but you're not going to have visual issues. I think diplopia has been described as like if you take way too much carbamazepine, but you're not going to have eye pain and visual changes, and certainly not pupillary defects. Okay, so you can get rid of C. Bell's palsy. Why not Bell's palsy? Bell's palsy is going to affect facial tone. Okay, so facial tone's intact. Myasthenia gravis. Kind of same story there. It's going to affect facial tone. Remember, myasthenia gravis, it's an autoimmune disorder. It affects the acetylcholine receptors at the neuromuscular junction. It's often characterized by facial weakness, but pain is really not a part of myasthenia gravis. And then Lyme's disease. So Lyme's disease, remember, is a systemic disease. It's caused from a bacteria, Borrelia burgdorferi, which is transmitted by the deer tick. And with Lyme's disease, it looks similar when it has neuromuscular signs. It's somewhat similar to Bell's palsy when it affects the face. You can get loss of tone. You can also, with the neurologic manifestations of Lyme's, you can get peripheral neuropathy and meningitis, but it's not associated with pain. Okay, so this patient has MS. MS is a chronic disease which involves inflammation and destruction of the myelin that insulates the nerves. Particularly here with MS, we're talking about the nerves of the central nervous system, not the peripheral nervous system. So you'll see this brain and spinal cord.
It is autoimmune in origin, and the associated signs are really a mixed bag of things. So really anything that affects an upper motor neuron, really anywhere in the brain, can cause a symptom of multiple sclerosis. And really it's, like I said, a mixed bag, because wherever you get these lesions, where you get demyelination, it's going to affect a certain function. So a lot of times we'll see dysfunction of cranial nerves, especially the optic neuritis, which we saw in this patient. You can get motor symptoms like weakness. You can get sensory symptoms like paresthesias. You can get autonomic symptoms like bowel and bladder incontinence. You can get cerebellar signs like ataxia and loss of balance. But these aren't going to be all present at the same time. It'll be one or another, maybe a couple that come on, but then gradually they'll go away. But then everything's going to come back again at another time. We call this relapsing remitting. MS, like in our patient, classically comes on in young women aged about 15 to 45 is the usual range. The average age of diagnosis is 30. It affects both men and women, but women are affected actually more than 2 times more than men. So about 2.5 to 1 is the ratio, but certainly can affect men as well. To diagnose multiple sclerosis, you can go one of 2 ways. In real life, we go straight for an MRI because we can see the demyelinating lesions very easily. On the test, you may see a CSF analysis. And I suppose that might be useful if you want to distinguish it from Lyme's, I guess, because you can do that with CSF. But we don't usually do that. We just go straight for MRI. But for the test, if you see CSF analysis, you want to know this word, oligoclonal. Oligoclonal bands. That is multiple sclerosis. Oligoclonal bands in the CSF is multiple sclerosis. But in practice, you usually go straight for an MRI, look for those demyelinating lesions, and this is what you see. These demyelinating lesions, these areas of white intensity. Okay, in particular, this is a gadolinium-enhanced MRI. Okay, so you see these demyelinating lesions. So let's take a better look here. I'll come back to this. Okay, so see these demyelinating lesions. The demyelinating lesions of MS tend to have a predilection for the periventricular areas. So here you see it along the lateral ventricles. See kind of a predilection of them. They also occur around the cortex. So here we call these juxtacortical lesions. And then they also have a tendency to occur along the corpus callosum, which you see here. And then also on the cerebellar peduncles, which we don't see at all here because we're not at that level. Okay, so just going back, the distribution of MS, you'll hear this a lot, that it's more in northern latitudes. So if you're in the northern part of the United States, as I am, or you go up even further north into Canada, you see MS a lot more than if you were to go down to Florida or Texas. You don't see it as much. Okay. So this is something that can happen with MS. You get what's called intranuclear ophthalmoplegia, which is basically where you have a lesion of this is going way back to anatomy, medial longitudinal fasciculus, which is responsible for coordinating eye movements. And so what happens is you have the patient look to the left, look to the right, and when you have intranuclear ophthalmoplegia, when you go to adduct, the affected side, that side is not going to adduct. Now remember, anytime you adduct one eye, you're abducting the other eye. So here you go look to the left, right side should be adducting, and the left side is abducting. Well, the left eye will abduct. The non-affected eye will abduct, but you'll get nystagmus with it. So what you have with INO is you have an inability of the affected side to adduct, and then the non-affected side, when you're looking, or when you're adducting, you're trying to adduct, I should say, the affected eye, when the non-affected eye abducts, you get nystagmus. Okay, so we didn't see that in this patient. What we did see in this patient, and go back here, is this thing with the pupil dilating when it's exposed to light. What that's called is a Marcus gun pupil. And so basically the Marcus gun pupil, it's just a delay in the response of the pupil. So let's say you shine your flashlight into the left pupil. Okay, the left pupil should constrict.
Okay, and so should the right pupil. Both pupils will constrict at the same time. Well, what happens then is you quickly move the flashlight from the left eye to the right eye, and there's a delay in that in the dilation. So once you remove the flashlight from the left eye, both pupils should dilate back. But because it's delayed, once you shine the flashlight into the right pupil, it's still in the process of dilating. So it looks like the pupil is dilating in response to the light. It's not. What's happening is it's just a delayed dilation. Whereas for those of us who don't have Marcus gun pupil, the pupil will redilate so quickly that by the time you get your flashlight over to the other pupil, it'll already be fully dilated and it'll constrict. Okay, so it's just a delayed dilation when the light is withdrawn. So, but it appears that the pupil dilates when it's exposed to the light. That's what you hear commonly referred. So this is called the Marcus gun pupil, and it's associated with MS. Okay, the treatment for MS is going to be steroids, and that's most commonly given for acute exacerbations. You can give either methylprednisolone IV or you can give prednisone. Prophylactic therapy is done with interferon beta or glutiramer, and then natalizumab is a newer drug that can be given as more second line, but I don't know, some doctors might be using it first line. But for the test, natalizumab is a second line agent. Baclofen can be used for spasticity because remember this is an upper motor neuron disorder. If you have upper motor neuron damage, you can have spasticity. Okay, I think that's okay. Oh, and yes, these are Dawson's fingers. So if you get a sagittal view and you look right around the lateral ventricles, you'll classically see these areas of demyelination, and they look like little fingers coming out the ventricles. And these are Dawson's fingers. You got to know that for the test because this is a classic association. Okay, question 4. A 21-year-old man presents to your clinic because of a 4-month history of fatigue. He says he gets 8 to 9 hours of sleep per night and occasionally wakes up sweating. He's still fatigued though. He says that during this time he has lost some weight despite not eating much less than usual and spending less time exercising because of his fatigue. He's 5'10" and 140 pounds, down from 162 pounds 6 months ago when he was in the ER for a broken finger. Vitals are 110/75, heart rate 85, respirations 13, temperature 99.8, saturation 100%. Physical exam is remarkable for bilateral supraclavicular lymphadenopathy. There is pallor of the mucous membranes. BMP is unremarkable. CBC is significant for a hemoglobin of 9.1, hematocrit 27.6, MCV of 88. SED rate is elevated. HIV ELISA is pending. CT reveals a mediastinal mass. No splenomegaly or other abnormalities. He is referred to a surgeon for lymph node excision, which reveals the presence of Reed-Sternberg cells. Bone marrow biopsy reveals similar cells. Which of the following is the next best step in management? A. Staging laparotomy. B. Radiation to the affected lymph nodes. C. Lymph node dissection. D. Doxorubicin, bleomycin, vinblastine, and dacarbazine. Or E. Cyclophosphamide, hydroxydoxorubicin, vincristine, and prednisone. Okay. So the answer here is D. ABVD chemotherapy. Doxorubicin, bleomycin, vinblastine, and dacarbazine. So what does this guy have, first of all? So the USMLE Step 2 and Step 3, they're going to want you to go a step further. Whereas Step 1 would have asked you, what does this patient have? Step 2 and 3 will ask you, they'll assume that you can figure out what he has, but then they'll ask you the next step. What do you need to do for this patient, i.e. what kind of treatment does he need? And so if you answered my question by saying he has Hodgkin's lymphoma or Hodgkin's disease, you would be correct. And you should know this from Step 1. Reed-Sternberg cells equals Hodgkin's disease. Always, always, always. This is pathognomonic. Reed-Sternberg cells is Hodgkin's disease. For Step 1, you need to know what Reed-Sternberg cells look like. Step 2 and 3, you don't. You're not going to be shown Reed-Sternberg cells. But you still need to know what they are and what they mean. Okay, so this guy's got Hodgkin's disease. Now, with Hodgkin's disease, once you diagnose it, the next step is to stage it. So you need to know something about how you stage Hodgkin's disease. In Hodgkin's disease, you don't need to know exactly what stage equals what features, but you do need to know that you have to stage it. And to stage it, you need to do two things. You need to get a bone marrow biopsy, and you need to get an abdominal pelvic CT. And essentially, we've done that here. So we got a CT, and we found nothing spleen-wise, which is really the big place we're looking. And then we got a bone marrow biopsy. But it doesn't even matter. The CT doesn't even matter because we found that he has affected cells. He has Hodgkin's in his bone marrow. And right there, that's a diagnosis of stage 4. So even if he doesn't have anything in his abdomen, it's stage 4 just based on the fact that he has it in his bone marrow. So this is stage 4 Hodgkin's lymphoma. What do you do for it? Chemotherapy. Okay, chemotherapy. Now the question is, what kind of chemotherapy? There's two different types of chemotherapy here. We have the ABVD chemotherapy and the CHOP chemotherapy. Cyclophosphamide, hydroxydoxorubicin, Oncovin or vincristine, and prednisone. So which one do we give? ABVD for Hodgkin's, CHOP for non-Hodgkin's. Okay, simple as that. You know that? Easy point on the USMLE. Okay. So Hodgkin's lymphoma is a monoclonic proliferation, usually of the B cells, and it's diagnostically characterized by the presence of these Reed-Sternberg cells, which are these sort of owl eye cells. Okay, so you gotta, if you're taking step 1 and you're watching this, you want to know what these look like. If you're taking step 2 or 3, this is what they look like, but you gotta know what Reed-Sternberg cells are. Okay, so Hodgkin's typically presents as painless lymphadenopathy. Usually it's cervical, but it can be supraclavicular. It can be anywhere, but most commonly cervical. And it just spreads. Okay, it spreads along the lymphatic system from where it's at outwards. Patients may complain, they might just have this, this node, or they might come in and say they are tired, and that's usually a sign that they've got something going on in their bone marrow, causing them to have an anemia. Or they may complain of these, what we call B symptoms, which is fever, weight loss, and night sweats. Any of those is a B symptom. And the fever has to be over 101.3. The weight loss has to be more than 10% in 6 months. And the night sweats, they say, has to require a change in clothes, but not everybody is going to do that. So I will point out here, just because it's interesting, there's what's known as the Pell-Ebstein fever, which is associated with Hodgkin's lymphoma. And what that is they have these febrile spells where they have a fever for usually like 101 degrees. And it lasts for a couple weeks, and then they go the next 2 weeks without any fever, and then they have the fever again. So it's this kind of fluctuating afebrile and febrile period. It's called a Pell-Ebstein fever, and it's classic for Hodgkin's lymphoma. You're not going to see it in all cases by any means, but that's something, I guess, to put in your back pocket. There's a bimodal age distribution for Hodgkin's lymphoma. So it tends to affect people in their 20s, so young adulthood, and 60s, so getting up there in age, late middle ages, elderly. And there's also a familial predilection. So look for family history of cancer. For diagnosis, we already kind of went over this. You want to get initial blood studies, chest x-ray, looking for that mediastinal mass, and then CT. You want to start out by at least getting a chest CT, but heck, if I were suspecting Hodgkin's lymphoma at all, I would just go the whole 9 yards and get chest, abdomen, and pelvis, and just get that out of the way. The definitive diagnosis is with lymph node biopsy. So anytime you suspect Hodgkin's lymphoma, you're always going to get that node out. Anytime you have a non-painful, kind of ongoing, lingering lymphadenopathy, but particularly non-painful, because that shows that it's not due to an infection, that lymph node probably needs to be biopsied. So you're going to biopsy it, and this is what you're looking for, the Reed-Sternberg cells. Once you see that, once you make a diagnosis this is some kind of malignancy, then you definitely need to CT the abdomen and pelvis, and then you need to get a bone marrow biopsy. Now, I put plus or minus bone marrow biopsy. Definitely get the bone marrow biopsy for the test, but in practice, some doctors won't do it because there's this whole risk calculator. But if you see malignancy in the spleen, for instance, you don't even need to do it anyway because you know it's stage 4. And so it does. Your bone marrow biopsy is just going to, it's not going to really give you anything. You're going to be giving this patient chemotherapy anyway. The bone marrow biopsy you have to do on both sides. So you get bilateral bone marrow biopsies. And the treatment is ABVD chemotherapy. Okay, that's doxorubicin, bleomycin, vinblastine, and dacarbazine. The A is doxorubicin, but it's based on the trade name, which is, I think, adriamycin. I don't know if that's a trade name or just a nickname for it, but A comes from adriamycin. Okay, so this is the chemotherapy for hematologic malignancies. I would say what you need to know for the test are, you want to know ALL and AML for sure. So for ALL, we start out with vincristine, prednisone, daunorubicin, and then methotrexate. AML, you use Ara-C and an anthracycline. Ara-C is the one you want to associate with AML because that one you don't see very much. If it's and this one often comes up in the test, if it's the M3 subtype of AML, you can give all-trans retinoic acid because with M3 it's a enzymatic blockage, and if you give this this ATRA, it relieves that, and then your cells will develop properly. CLL and CML, the one you really need to know is CML. You give imatinib. If it's Philadelphia chromosome positive, most of them are. So imatinib for CML. Hodgkin's, we said, is the ABVD chemotherapy, ABVD. With non-Hodgkin's, it's CHOP, or you might otherwise hear it R-CHOP, where you just add rituximab to the CHOP chemotherapy. And then multiple myeloma, you'll want to know this one as well. Younger patients, we treat a little bit more aggressively because we're setting them up for bone marrow transplant. Older patients, a little bit less aggressively because the chemo would probably kill them before the multiple myeloma. Okay. Question 5. A 44-year-old woman presents to your clinic complaining of weakness and back pain for the last 2 months. She has a past medical history of type 2 diabetes and hypertension, for which she takes metformin and lisinopril hydrochlorothiazide. She smoked a pack per day for the last 25 years, but she does not drink or do illicit drugs. She works as a bartender and has been married for 15 years. She's premenopausal and has 2 children born term spontaneous vaginal deliveries. Cycles are regular. Review of systems reveals some constipation, which has coincided with her back pain. She's 5'4", 195 pounds, which puts her in the obese range. Vitals are stable. Physical exam is remarkable for point tenderness at the thoracic spine. Normal range of motion. There are crackles in the left upper lung field. Abdomen is soft, non-tender, non-distended with diminished bowel sounds. Labs show an albumin of 3.4, calcium of 13.5, phosphorus of 2.9, chloride of 108. BUN of 38, creatinine of 1.8, CBC is unremarkable. Chest x-ray reveals a solitary 1.2 centimeter confluent, non-calcified lesion in the left upper lobe. Which of the following is the best next step of management in this patient? A, bronchoscopy, B, fine needle aspiration of the lesion, C, thiazide diuretics, D, bolus of normal saline, or E, bisphosphonates. Okay, so the answer to this one is D, a bolus of normal saline. So what does this patient probably have? Well, what do we know she has, and what do we think she might have in addition to that? So we know she's got hypercalcemia, symptomatic hypercalcemia. Okay? She's got a high calcium level, and she's got these signs of hypercalcemia. Not really blatant signs, but she's got some well, that's not a sign of hypercalcemia, I guess, but she's got constipation. Okay, constipation, if you have constipation, you're not necessarily going to get calcium, but if you already have a high calcium level and the patient has constipation, well, then you know where the constipation is probably coming from. But what do we think she probably has in addition to this? Well, she's a smoker, and importantly, we got a chest x-ray, and we happen to find a new lesion. I guess I didn't put new lesion here, but you can assume that if they give it to you on the test. You always want to compare
chest x-rays to previous chest x-rays, but if you're not told otherwise, just assume it's a new lesion. So the chest x-ray shows this new lesion. It's big, it's 1.2 centimeters, and it's also non-calcified. Calcification of a lesion is a good thing. If it's non-calcified, that is consistent with malignancy. And so what she probably has is hypercalcemia of malignancy, and it's secondary to a squamous cell carcinoma, which we know produces parathyroid hormone-related peptide, PTHrP. And that can cause high calcium levels, which can then cause her symptoms. The back pain may be due to decalcification of her spinal bones, and then the constipation is coming from the high calcium levels. Now, the very first thing that we want to do in a patient with hypercalcemia is we want to give them fluids, okay? Why do we give fluids to a patient with hypercalcemia? The answer to that is that they're probably dehydrated. Okay, so we do fluids first. Okay, fluids first for hypercalcemia. Now look at her renal function tests. She has a BUN of 38 and a creatinine of 1.8. The BUN creatinine ratio is above 20. What does that mean? She's probably dehydrated. Okay, so we're going to give her fluids. Even if it weren't, we're still going to give her a bolus of fluids. So that's the first step in treating hypercalcemia. Okay, is to give fluids. You can add furosemide to that, but you don't have to. But you got to give her fluids. The furosemide can help because furosemide helps you clear calcium, so you might add that. Now, let's go back here. Why not bisphosphonates? Don't bisphosphonates lower your calcium level? And the answer is, of course they do. But, like I said, she's probably dehydrated. That's why we don't jump in and give her thiazide diuretics. Well, aside from the fact that thiazide diuretics can actually raise your calcium levels. If let's say I had put loop diuretics here. Can we give her loop diuretics? Sure, that would lower your calcium level, but she's probably dehydrated, and we need to treat her dehydration first. And that may also be contributing to your constipation, by the way, too, because if you're dehydrated, you're going to be constipated. So thiazide diuretics are an absolute no-no here, because thiazide diuretics can raise your calcium level. Plus, she's already dehydrated, so we don't want to give her diuretics. Bolus of normal saline is the correct answer, because she's dehydrated, because she's got hypercalcemia, probably dehydrated, okay? You got to remember, anybody coming in with a hypercalcemia, they're probably dehydrated, so you're going to bolus them with normal saline, and you might add furosemide to that. Bisphosphonates are only given in the event that we rehydrate her and she continues to have a calcium either above 14 or if she remains symptomatic. Now, what are the symptoms of hypercalcemia? The common mnemonic is bones, stones, groans, and psychiatric overtones. So what's bones? Bones can be fractures and pain. Why? Because you're decalcifying the bones. That's going to cause fractures or microfractures, and that can lead to pain. Stones. Well, that's obvious. You have a high calcium level, you're predisposed to calcium stones, nephrolithiasis, kidney stones. Abdominal groans. Probably relates a lot to the constipation. So the constipation, you get abdominal pain, you get nausea, vomiting. Everything gets kind of slowed down because calcium tends to slow you down, sort of stuns your nervous system. And so they can get anorexia because everything gets slowed down. If you're constipated, do you really want to eat? Probably not. So that's probably how those are related. And then psychiatric overtones. Like I said, kind of stuns your nervous system. Your nervous system is going to be a little less responsive, whereas with hypocalcemia, your nervous system is very excitable. So with hypercalcemia, I like to think of it as the nerves are become too stable. And so they're very hard to excite. So you become weak, you become fatigued, your deep tendon reflexes are diminished, whereas with hypocalcemia, low calcium, you're more jittery, maybe not sleeping a lot, your deep tendon reflexes are exaggerated, etc. And then altered mental status in severe hypercalcemia. So when we give bisphosphonates, if they don't respond to fluids and furosemide, and they remain symptomatic, or if even if they're not symptomatic, their calcium level is above 14. But still, the very first step is fluids plus or minus furosemide. Bisphosphonates are given after that if the patient remains symptomatic or the calcium stays above 14.
Hemodialysis is the last resort. So this is your workup for hypercalcemia. So assuming you already got calcium levels, phosphate levels, you want to check albumin, check ALK-Phos, and then consider some of these other things which may give you some insight as to what might be causing it. So vitamin D levels, serum protein electrophoresis, the possibility of multiple myeloma, parathyroid hormone, that's a big one because the number one cause is going to be hyperparathyroidism. Parathyroid hormone-related peptide is going to be associated with a lot of squamous cell cancers, so like the lung here, which is probably what it is because we saw the lesion on chest x-ray. Also the skin, head and neck, breast, bladder, ovary, any of those squamous cell cancers can give you this parathyroid hormone-related peptide. Another cancer that can do it is lymphomas and leukemias, kind of a black sheep there. You get a TSH and then do imaging. What are the causes of hypercalcemia? The mnemonic is chimpanzees. Okay? You can memorize however many of these you want. The big ones though, calcium supplements, some people take too much. Hyperparathyroidism, really the number one cause. And then I would say excess vitamin D. A lot of people are taking vitamin D now. It's like the new fad. So you want to look out for that. And then sarcoidosis, classic hypercalcemia. Okay. Okay, question 6. A 30-year-old man presents to your clinic complaining of low back pain, which has been lingering for the last 3 years. He says that the pain was bearable until recently because he had been working a desk job, but now he got a promotion and is doing much more walking, and the pain has gotten in the way. The pain is worse in the morning for a few hours after he wakes up. It persists throughout the day, but is less severe. He also has pain in both knees, but this is less severe. Past medical history is significant for an eye issue, which caused him to go to the ER last year. He says that he had eye pain and blurriness and was discharged without a diagnosis, but it resolved on its own a couple weeks later. Typical ER doctor, right? No diagnosis, just go home. He's 6 feet 1 inches tall, 180 pounds. Vitals are within normal limits. Physical exam is remarkable for tenderness over both sacroiliac joints, reduced range of motion and spinal flexion. Knees are mildly swollen, but not tender to palpation. There's a mild diastolic murmur over the right sternal border. Lungs are clear to auscultation. Labs demonstrate an elevated ESR. CBC and BMP are within normal limits. Which of the following is the most likely diagnosis in this patient? A. Rheumatoid arthritis. B. Ankylosing spondylitis. C. Osteoarthritis. D. Lumbar canal stenosis. Or E. Pseudogout. Okay, the answer to this one is B. Ankylosing spondylitis. So why do we think this is ankylosing spondylitis? Well, the pattern of his pain, first of all, so the pain is worse in the morning and gets better throughout the day. That's classic for a rheumatic disease, one of those autoimmune diseases. So RA would fall into that category. Ankylosing spondylitis would fall into that category. Osteoarthritis would not. Osteoarthritis will get worse as the day goes on. Okay, if you have a grandparent who's got arthritis, and they sit down at 7 o'clock at night, oh, my knees hurt. That's osteoarthritis. It gets worse with activity. Lumbar canal stenosis is totally different. Lumbar canal stenosis does not have early morning pain. It's worsened by things like standing, and it's not going to get better throughout the day. What about pseudogout? Absolutely not. We talked about pseudogout. Right? It doesn't look like this. So we're between RA and ankylosing spondylitis. So why do we think this is ankylosing spondylitis? Well, the first giveaway, you can kind of say, is his age and his sex. He's a young guy. Young guys tend to get ankylosing spondylitis. Ankylosing spondylitis tends to present in young guys. Okay, RA is more of a female disease to equal. Ankylosing spondylitis has a predilection for men, okay, particularly young men. But also, the pain is not in his fingers and wrists like we would see with RA. The pain is more back or hip pain. That's ankylosing spondylitis. RA is like wrists and fingers. Ankylosing spondylitis is like back and hips. Now, he has some knee pain, right? And knee pain can be associated, because ankylosing spondylitis is really a systemic disease, you can get knee pain with ankylosing spondylitis. But I could take this out, and it would still be ankylosing spondylitis.
What's the other thing that makes you think ankylosing spondylitis? I'll give you a hint. It wasn't there because I felt like putting it in. It's this eye issue. Okay, what is this that he's got? An eye issue, painful, caused blurriness, went away on its own. Anterior uveitis. Anterior uveitis is associated with the seronegative spondyloarthropathies, okay, which we can go on, I guess, here now. Seronegative spondyloarthropathies include things like psoriatic arthritis, Reiter syndrome, also known as reactive arthritis, enteropathic arthropathy, juvenile arthritis, and of course ankylosing spondylitis is the big one. I would say ankylosing and psoriatic arthritis are the two big ones. What do these share in common? Most of the patients who have this will be HLA-B27 positive. Okay, so you want to remember HLA-B27 with the seronegative spondyloarthropathies. If the patient is not white, they're less likely to be HLA-B27 positive, even though they still have the seronegative spondyloarthropathy. So you have a white guy with ankylosing spondylitis, he's much more likely to drop a positive HLA-B27 titer than a black guy would, but they can both have ankylosing spondylitis. Classically, ankylosing spondylitis presents as low back pain in a young guy, usually 20s and 30s, and very similar to RA, it's worse in the morning and improves throughout the day, but unlike RA, it's in the back. Okay, whereas with RA, it tends to be fingers and wrists are more affected. Okay, there's some overlap, but that tends to be how it is. Ankylosing spondylitis is associated with anterior uveitis, gotta know that, and then also aortic regurgitation, and that was his murmur that we heard, that diastolic murmur. To diagnose ankylosing spondylitis, it's pretty simple. Get lumbar and pelvic x-rays. The features that you see on x-ray with ankylosing spondylitis is pretty much pathognomonic. You don't really need to do anything else. HLA-B27 titers are good to confirm your diagnosis, but remember that not all patients with these seronegative spondyloarthropathies are going to be HLA-B27 positive. But if they do come back positive, that points you towards your diagnosis. The treatment is NSAIDs and physical therapy. More and more commonly, they're giving the TNF inhibitors. These are things like infliximab, also known as Remicade, adalimumab, also known as Humira, and etanercept, also known as Enbrel. And these are used for ankylosing spondylitis, as well as some of the other rheumatic diseases. Okay, so what you see with ankylosing spondylitis is you see calcification or ossification of the ligaments along the spine. And so what it looks like is that the spinal bones are connected to each other along the anterior side. And this is called syndesmophytes. It's a fusion of the vertebrae. And what you'll see, so we'll come back to that. So here's a normal spine, right? See, these spines are nice and separated. They only articulate in the back, not in the front. Well, here you have the syndesmophytes. And this is what you see with ankylosing spondylitis. So note here that you have calcification here. All right. So ossification of the spinal ligaments is what gives you these syndesmophytes, and you can see that you don't have that clear space in between the vertebrae. Now, when you look anterior-posteriorly, it has a characteristic appearance. Look at that. Okay, so you have a sort of an obliteration of this clear area here, and it's filled in with this calcific material. And what it looks like, I mean, you have your, okay, here's a better picture. What it looks like is this, bamboo. Okay, so note these lines here, which is where the syndesmophytes are, and then the spinous processes, you'll see that, but this is the bamboo spine. Okay, so you hear bamboo spine, and that's pathognomonic for the most part for ankylosing spondylitis. Now, what else do we see? So here's a normal hip, okay, and what we're looking at is the sacroiliac joint. So this is the sacroiliac joint right here and right here. And with the sacroiliac joint, what we see in ankylosing spondylitis is we see sclerosis. So note all this white here.
This is sclerosis at the sacroiliac joint, and this is why he has pain there. Now, what do we mean when we say seronegative spondyloarthropathy? What we mean is that their rheumatoid factor will be negative. Okay, now with RA, it's oftentimes positive. With ankylosing spondylitis, psoriatic arthritis, all those things, the rheumatoid factor is always negative. Okay. All right, moving on. Question 7. A 47-year-old man presents to the clinic for annual physical exam. He is in good health and does not have any complaints at this time. His past medical history is significant for major depressive disorder, which was controlled with venlafaxine, otherwise known as Effexor. But he has stopped treatment 5 years ago and has had no further depressive symptoms. He smokes a half pack per day for the last 25 years. He has 1 or 2 drinks with friends on the weekends and denies illicit drugs. He exercises regularly and watches his diet. He works full-time as a nurse practitioner and says that he finds it difficult to go the entire workday without having a cigarette. He would like to quit smoking, but does not think he can do it without help. He has tried nicotine gum, but he doesn't like the taste. He's also tried the patch, but it caused a skin reaction. Which of the following would be the most appropriate treatment plan for this patient? A. Acupuncture, B. Group therapy, C. Varenicline, D. Bupropion, or E. Electronic cigarettes. All right. Pause it here. And the answer is bupropion. So, out of all of these, only 2 of these are considered first-line pharmacotherapies for smoking cessation. So there's really 3 of them, right? So the first one is nicotine replacement. You can always do nicotine replacement, the gum, the patch. They even make like an intranasal spray. But this guy's tried those and he hasn't liked it. He didn't like how the gum tastes. The patch caused him to break out. So we're not going to do that, and that's not even a choice here. The other 2 pharmacotherapies are varenicline, which is marketed as Chantix. You may see that on TV. And bupropion, which is used for depression, marketed as Wellbutrin, and is also used, marketed as Zyban for smoking cessation. So either of those 2 in your average patient would be fine. You could take your pick. Okay. Acupuncture, not proven to be useful. Group therapy, not proven to be useful. Electronic cigarettes, not proven to be useful or safe. And probably wouldn't even be good anyway because you've got to smoke that, and he doesn't want to smoke inside. Okay, so varenicline or bupropion. Why is this patient a better candidate for bupropion and not a good candidate for varenicline? Varenicline is associated with psychiatric adverse effects, and you don't want to give it to somebody who has any kind of psychiatric history. Now, that's not I would say it's not anybody with an active psychiatric history, so they have current depression or they have current schizophrenia, absolutely no varenicline. A remote psychiatric history, you'd have to use with caution, but you still want to use something else if you can. Bupropion is better in this patient because it doesn't have those psychiatric side effects. Bupropion actually would help depression, if anything. Now, there are certain patients we can't give bupropion in, and who would that be? And this would be a 90th percentile question on the USMLE. The absolute contraindication for bupropion, seizure disorder. Okay, so if I told you everything said, took out he has a history of major depressive disorder and put in he has a history of seizure disorder, even if it's remote, no bupropion, then you go for varenicline. But because he has a psychiatric history, we want to steer clear of varenicline and go towards bupropion. Okay. So varenicline is associated with depression, psychosis, anxiety, agitation, and also can cause seizures, but seizures aren't a contraindication for varenicline like it is for bupropion. And it can also cause, varenicline can also cause sleepwalking. So because of all those psychiatric adverse effects, we try to avoid it in patients with any kind of significant psychiatric history or ongoing psychiatric problems. Bupropion is good for those patients, but you don't want to give bupropion to somebody who has or has had a seizure disorder. Okay? So cigarette smoking is a major modifiable risk factor for things like heart disease, high blood pressure, all those nasty things that kill a bunch of people. And it's associated with 443,000 premature deaths every year in the US and costs almost $100 billion in lost productivity. Even though the number of people in the US who smoke has gone down over the last 20, 30 years, still about 20% of Americans smoke regularly. The pharmacotherapy, nicotine replacement, bupropion, varenicline, these are the most commonly used agents. Okay, moving on. Question 8. A 37-year-old man presents to your clinic complaining of general malaise and fatigue for the past month. This has been worsening with time, and he's very concerned because his dad had similar symptoms when he developed lymphoma at age 41. There is a past medical history of seizure disorder, and his last seizure was 8 months ago. We're saying in this patient, he has a seizure disorder, and his last one was 8 months ago. Medications include lamotrigine and phenytoin. He drinks about 3 or 4 beers per night and has been trying to cut down on the advice of his neurologist. Shouldn't be drinking if you have seizure disorder. He denies smoking or illicit drug use. He is 6 foot 3 inches tall and 200 pounds. Vitals are within normal limits. Physical exam is remarkable for mild pallor and a red, swollen, beefy tongue that the patient says is mildly painful. Cranial nerve, sensory, and motor exams are unremarkable. There's no lymphadenopathy. Labs reveal hemoglobin of 9.4, hematocrit 27.9, white blood cell count of 8, platelets 375, MCV of 115. Smear reveals oval macrocytes and hypersegmented neutrophils. Which of the following is the most likely cause of this patient's presentation? A. Folate deficiency anemia. B. Vitamin B12 deficiency anemia. C. Iron deficiency anemia. D. Aplastic anemia. Or E. Myelofibrosis. And the answer here is A, folate deficiency anemia. So we can narrow it down to 2 of these just based on his labs. Okay, so he has anemia, we know that. But what type of anemia does he have? He has a macrocytic anemia. The MCV is over 100, it's 115. So knowing that he has a macrocytic anemia, that narrows it down pretty good. For the most part, macrocytic anemias are caused by folate deficiency or B12 deficiency. Okay, there's some other causes like liver disease and alcohol abuse and hypothyroidism, but they're not common. Folate deficiency is the most common, and then followed by B12 deficiency. And you see this a lot in alcoholics because they often have nutritional deficiencies. So folate deficiency or B12 deficiency. These other ones, iron deficiency, is that going to cause a macrocytic anemia? No, that's going to cause a microcytic anemia. So if MCV was 72, then we would look at iron deficiency anemia. Aplastic anemia, why not that? Well, aplastic anemia would be a normocytic anemia, so 80 to 100 MCV, but it would also affect the white blood cell count and the platelet lines. Okay, so our white count and platelet count are normal. So if he had a white count of 2.3 and a platelet count of 70 and an MCV of 89, then aplastic anemia would be a possibility. You'd really want to look at your reticulocyte count because if that were low, that would be pointing towards aplastic anemia, but that's not the case in this patient. And then myelofibrosis. This is also going to, in many cases, affect other cell lines. And so because you can get, because it can affect other cell lines, a lot of them will show up with bruising, infection. They can, the fibrosis, the myelofibrosis, what it is really a malignancy, and those malignant cells can get into the spleen, so it can cause like a splenomegaly. So that's not going on in this patient. So you're between folate and B12. Why folate? Folate is more common, first of all. It's much easier to get a folate deficiency because you can store vitamin B12 much easier. And vitamin B12 comes from meat, and we tend to eat meat a lot in the US. Folate comes from vegetables. We're not so good at that. But folate deficiency is likely the case because of his medications. He's on phenytoin. And phenytoin is going to lower your folate count. Now, some people say it's a folate inhibitor or an anti-folate. That's not exactly right. What it does is it actually reduces the production of folate from precursors in the diet. It inhibits an enzyme in the intestine. Very complicated. But it will lower your folate count. Let's just put it that way. Okay, so this is folate deficiency anemia. Folate deficiency will also give you this beefy tongue. This is called glossitis, but B12 deficiency will do that too. So that's not particularly specific.
The smears also point towards a macrocytic anemia, so you'll see oval macrocytes and hypersegmented neutrophils. But that, again, doesn't tell you the difference between folate and B12. We go to folate because of the fact that he's on this medication and that this anemia coincided with the phenytoin. So folate deficiency is a major cause of macrocytic anemia along with B12 deficiency, and that's going to show you a high MCV and hypersegmented neutrophils. The major risk factors include medications, so phenytoin, and methotrexate is another one. Another one is zidovudine, which is given for HIV, and then alcoholism. Lack of fresh fruits and veggies in the diet will worsen this, and if you think about it, like 90% of Americans don't get their daily value of fruits and vegetables, so not uncommon. Symptoms include anemia, angular stomatitis, which they get little sores in their mouth and along the sides of their mouth, glossitis, which we saw in this patient. You have to differentiate this from B12 deficiency because you see all those things in B12 deficiency, but what you see in B12 deficiency that you don't see in folate deficiency is neurologic signs. So things like paresthesias and sensory neuropathies, especially affecting the hands and feet, leg stiffness, paraplegia, they can even go as far as dementia. So the fact that this guy doesn't have that points us away from B12 deficiency, along with his phenytoin. Diagnosis is either clinical or ideally you should get a folate level just to confirm. And then treatment is supplementation and manage the underlying cause. Now, what are some of these underlying causes? The mnemonic is AFOLICPOD, AFOLICPOD. Okay, now, some of these are more obvious. Alcoholism, because they're malnourished. Folic acid antagonists, because it reduces their production of folic acid. Dilantin, because it inhibits the conversion of dietary things to folic acid. Oral contraceptives, don't think of that one too much. Low dietary intake, duh. Infections, probably because it's affecting the intestine and there's that enzyme there. Remember that enzyme I was telling you about that dilantin inhibits? It sits in the jejunum. And so anything that diseases your intestine, your small bowel, is going to affect that enzyme and it's going to lower your folic acid level. Okay, so that's like giardiasis, celiac disease. Often people with inflammatory bowel disease can have that too. Pregnancy, because you need folate for 2, and if you're only getting folate for 1, where's it going to go? It's going to go to baby, and you're going to be folate deficient. Psoriasis, because your skin is, you have increased skin turnover, and so because of that, you need more folate. Old age, not sure why, and then dilantin. Okay, so those are your causes of folate deficiency. So that's that big swollen beefy tongue, also known as glossitis, and this is your hypersegmented neutrophil. Okay, question 9. A 40-year-old woman presents to your clinic complaining of pruritus that has become so severe that it's causing difficulty sleeping at night. She says that this has been going on for the last 6 months, but has been getting worse. She is also fatigued, but she attributes this to difficulty sleeping. Okay. She has otherwise been in good health and takes no medications. Family history is significant for RA and 2 of her sisters. She's 5'8", 145 pounds, which is down from 165 pounds 3 months ago. She says this weight loss has been unintended. Vitals are stable. Physical exam is remarkable for jaundice and scleral icterus, along with linear excoriations to her arms and neck. Her liver is palpable 4 centimeters below the costal margin, mild right upper quadrant tenderness. Labs show an AST of 52, an ALT of 67, ELK phos of 720, total bilirubin of 8.5, conjugated bilirubin 7.9. Which of the following is the best next step in the management of this patient? A, liver biopsy. B, anti-mitochondrial antibody, or AMA. C, anti-nuclear antibody, or ANA. D, anti-smooth muscle antibody, ASMA. Or E, PANCA, also known as perinuclear antineutrophil cytoplasmic antibody. Okay, I'll give you some time to pause it. This is a tough one. The answer here is AMA, anti-mitochondrial antibody. So in order to answer this question correctly, you need to have a presumptive diagnosis. And that's the hard part here. Okay, so you need to have a presumptive diagnosis, and then you need to know how you diagnose that. So what's our presumptive diagnosis here? Well, first of all, evaluating her, she's got jaundice, and or at least she's got, yeah, she does have jaundice, okay. So she's got jaundice, and she's got pruritus. Pruritus probably coming from the jaundice. And then she's got weight loss.
And then her labs show something going on with the biliary tract. So you look at AST and ALT, right? Your transaminases. And those tell you how the liver itself is doing, how the hepatocytes are doing. The ELK phos tells you how your biliary tract is doing. And so if you have relatively normal transaminases but a high ELK phos, tells you that the problem is in your biliary tract, anywhere from the intrahepatic ducts to the extrahepatic ducts. Okay, so we know there's something going on with the biliary tract here. And we know that she's got a conjugated hyperbilirubinemia, as we would expect if there's something really seriously wrong with the biliary tract. Okay, so she's got some kind of biliary tract issue. Her weight loss is probably because of the fact that she's not getting bile into her intestines, so she's having malabsorption. So you have a woman who has sudden biliary tract issues, but she doesn't have pain, right? There's some mild tenderness, but she doesn't have real pain. She's got some hepatomegaly. What do we suspect? Well, probably not hepatitis, because hepatitis would be infectious, and you get a fever, and aches and pains and stuff like that. If it was Hep A, she'd be really sick. And this has been going on for 6 months. So it's probably not hepatitis. And also with Hep B and C, we would expect IV drug use, blood transfusion, stuff like that. Unprotected sex. So what this probably is it's probably primary biliary cirrhosis. And this is idiopathic, and it just shows up. And it classically shows up in middle-aged women. I think like 90% of PBC patients are women. Okay, so if we think it's primary biliary cirrhosis, then the test that we want to do is the antimitochondrial antibody, because that has the best specificity for primary biliary cirrhosis. Okay, the ANA, the anti-nuclear antibody, is what we would get if we suspected this to be autoimmune hepatitis. And with autoimmune hepatitis, you'd have a somewhat similar picture, although those patients are a lot less symptomatic. But what you would expect to see is really high AST and ALT levels, your transaminases, because this is affecting the liver itself, not the biliary tract. The ELK phos level would be closer to normal. ASMA is really not specific. It can be elevated in all sorts of things, so that's not diagnostic for anything. And then p-ANCA is what we use to diagnose primary sclerosing cholangitis. And primary sclerosing cholangitis looks just like PBC symptomatically. But the difference is PSC tends to occur in men, and it tends to coincide with inflammatory bowel disease, mostly ulcerative colitis. And so because this woman does not have ulcerative colitis, and she's not a man, we think that this is probably primary biliary cirrhosis. Okay, so the first thing we do is we get titers of those antibodies, and then we can go on and get a liver biopsy for definitive diagnosis. Okay, so this is just comparing those autoimmune hepatobiliary diseases, and you want to know this. I would copy this down. Okay, so I highlighted the ones that will help these stand out from one another. So primary sclerosing cholangitis stands out because it tends to happen in males. It also stands out because of its association with inflammatory bowel disease. Autoimmune hepatitis stands out because it has high transaminases. The other ones, not so much. The other ones have high to very high ELK phos levels, be PBC and PSC. The autoantibodies is what you really need to remember. So autoimmune hepatitis is ANA, primary biliary cirrhosis is AMA, and primary sclerosing cholangitis is p-ANCA. Okay, if you know those, that will help big time on the test. The other thing you need to know is the best diagnostic test. So with autoimmune hepatitis and primary biliary cirrhosis, you get a biopsy. And that makes sense because autoimmune hepatitis is a disease of the liver tissue itself, the hepatocytes. Primary biliary cirrhosis is a disease that affects both the intrahepatic ducts, which are in the liver, and the extrahepatic ducts, which are outside the liver, but it affects ducts in the liver, so a liver biopsy would tell you that. Primary sclerosing cholangitis primarily affects the extrahepatic ducts, the bigger ducts. So it's not so good for liver biopsy is not so good for primary sclerosing cholangitis because you're not necessarily going to see any changes in the liver. Where you will see changes is in those bigger ducts, those extrahepatic ducts. And so getting a cholangiogram would be much more useful for primary sclerosing cholangitis because you're putting that dye in and you'll see these areas of fibrosis alternating with dilatation. You see these mucked up biliary ducts. That's primary sclerosing cholangitis. Okay, as far as liver biopsy, to distinguish AIH and PBC, aside from the fact that one has high transaminases, the other has high ALK phos, with PBC, if you get a liver biopsy, you'll see granulomas. The treatment for PBC is ursodeoxycholic acid, which is basically a synthetic bile, which you give the patient, and it helps them absorb fats and vitamins. That's one of the big complications if you're not getting bile, is malabsorption. You can also give them cholestyramine. Cholestyramine is a bile acid sequestrant, and that blocks reuptake into the enterohepatic circulation. So because you're blocking reuptake, you're not going to have as high of, it's going to reduce your levels of bilirubin. So that can be helpful. As far as like the itching goes and stuff, which is some of the major symptoms of PBC. And then for the definitive treatment for PBC and PSC is transplant. Ultimately, with PBC and PSC, these patients are going to go towards end-stage liver disease. So transplant is the definitive diagnosis, but a lot of these patients will still have recurrence. PSC, you can do biliary stenting because it's more of a macroscopic issue with their biliary tract. With PBC, it's much more microscopic. With autoimmune hepatitis, the difference is with the treatment, we give steroids and azathioprine, and that tends to be good enough. Okay. All right, last question, question 10. A 20-year-old man presents to the ED complaining of severe chest pain over the last 3 hours. He says that he was fine this morning when he went to the gym, where he has recently started a rigorous weightlifting program, but the pain came on during dinner this evening. He describes the pain as a +8 out of 10, sharp and localized to a discrete region on the parasternal chest wall. He has no significant past medical history and takes no medications. Family history is significant for a heart attack in his dad at age 57, and this has him somewhat concerned. He's 5 feet 10 inches tall, 165 pounds. Vitals are within normal limits. Heart sounds are normal and there's no murmur. Lungs are clear to auscultation. Chest pain is worsened with deep breathing, movement, and is reproducible with palpation of the affected region. Which of the following is the best next step in the management of this patient? A, cardiac stress test. B, cardiac enzyme titers. C, antacid and viscous lidocaine. D, NSAIDs and rest. Or E, chest x-ray. Okay, so triage this patient and figure out what he's got. The answer is D, NSAIDs and rest. So you got a guy coming in with chest pain. Normally that's red flags, get an EKG, get cardiac enzymes right away, do all those things. This guy's 20, right? And his pain has been here for 3 hours, okay? So it's probably nothing really severe, especially when you take into consideration his age. Young people don't get heart attacks, okay? Not 20-year-olds. 20-year-olds don't get heart attacks. Okay, but there's some things in his history that really stand out. First off, this came delayed after weightlifting. Well, what do we know weightlifting does? It causes muscle pain, okay? And so if he's bench pressing, probably pulling some muscles, okay? And that is likely our diagnosis, costochondritis. Now, what are some other things that point to costochondritis? This one you really got to know. Anytime you can worsen, so you have a patient with chest pain, anytime you push at their chest and that causes the same pain, that is likely costochondritis. Musculoskeletal chest pain, absolutely nothing to worry about, at least not like a heart attack. Okay, so you have a young person coming in saying they have chest pain. If they can point to where that pain is and it's in one specific location, if they're using their finger to point at where the pain is, that's very localized and it's probably costochondritis. On the other hand, if they're using their hand and they're kind of moving their hand to show you kind of where the pain is and it radiates and stuff, that may be something else. Usually in a young person, if it's not costochondritis, it's probably something like reflux disease. So if he was pointing at his chest and saying, oh, it kind of comes up here and it burns and it came on a couple hours after eating, that's reflux. Now, what about the fact that his dad had a heart attack at 57? Do we have to be concerned about that? 57 is not an uncommon age to have a heart attack. Now, if his dad was 37, then we're probably going to get a lipid panel on this guy. Well, if not, if he's 8. But he's going to need a lipid panel at some point. Then we might be concerned enough to get an EKG because there might be an FH thing going on. But otherwise, there's nothing here that has us concerned about any kind of heart attack. Now, in practice, would you get an EKG? Would you get cardiac enzymes? We pretty much order it on everybody who has chest pain who comes in, even if they're like 9. But for the test, you need to know what costochondritis is. It's musculoskeletal chest pain, and it is one of the more common causes of chest pain in young people, especially after activity. So cardiac stress testing we would do for somebody who has what looks like angina. It would not be something we would do in the ER, though. Cardiac enzyme titers, yeah, maybe if he was older or we couldn't rule out MI or we didn't have this very clear diagnosis of costochondritis. Antacid and viscous lidocaine, this is the GI cocktail, the famous GI cocktail, which we give for people with reflux disease. So if they're having reflux and they're still having pain, give them that. If the pain goes away, it was probably reflux all along. NSAIDs and rest are the treatment, so send them home with Tylenol, maybe Tylenol with codeine if you're really feeling daring. And then rest. Don't go back to the gym for a few days because that's what's causing your pain. Rest it and then take it a little bit easier at the gym from here on out. And chest x-ray, not valuable. Really, chest x-ray is only going to be of value if you're suspecting things like pneumonia, which can cause chest pain, pleurisy, or aortic dissection. None of those in this patient. He doesn't have a fever, doesn't have radiating pain to the back. He's not 50, so we don't need to get a chest x-ray for him. For him, it's just NSAIDs and rest. And that is all I've got.